Hello, my name is Dr. Christoph Corell. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for episode 1 of a 3-part CME OCAS series on reducing symptoms and restoring function in patients with schizophrenia. What's the latest evidence? Today's episode is titled Long-Acting Injectables for Schizophrenia, an effective yet often underutilized tool for rapid symptom reduction and restoration of function. This activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians across the globe. I am a professor of psychiatry and molecular medicine at the Zucker School of Medicine at Hofstra Northwell in Hempstead, New York, and the medical director of the Recognition and Prevention Program at the Zucker Hillside Hospital, Department of Psychiatry in Glen Oaks, New York. Our learning objective today is to evaluate the impact of LAIs on quickly stabilizing patients with acute schizophrenia and facilitating seamless long-term maintenance. So let's take a look at how clinicians evaluate the prescribing potential of long-acting injectable antipsychotics, or LAIs, in their practice. When German psychiatrists were asked why they are not utilizing long-acting injectables despite ample evidence of efficacy and safety, 86% of them said that they believe their patients have sufficient adherence to oral medications. This is a very surprising assertion, because we know from data that between 50 and 75% of patients within 1 to 2 years will not take the medication as prescribed when we talk about antipsychotics and schizophrenia. However, clinicians are very good at knowing these numbers for their colleagues' patients. They realize that yes, in general clinical care, many patients stop medications. However, there's an overestimation of the adherence that patients might have in their own practice because they return for care, they have an alliance with them, and we do not adequately measure true treatment adherence. Moreover, 80% said, well, when I offer it, actually my patients refuse. They will not accept antipsychotic treatment. 3/4 said, maybe I would like to prescribe them, but unfortunately that very medication I want to use is not available as an LAI. Also, cost considerations were relevant for 71%. However, the cost of medications has been shown over and over again to be far lower than the cost of care when patients are non-adherent and relapse. Why do clinicians not offer LAIs as much as most likely would be clinically appropriate? A study from Norway could show that on almost all aspects where clinicians rated potential concerns that patients might have with long-acting injectables, they were 20 to 50% higher in their estimate than the actual patients themselves. This included feeling stigmatized, feeling controlled, wouldn't be able to decide when the medication is taken, feeling less self-dependent or embarrassed, or feeling pain. In each of those outcomes, even patients on current oral medications had a far lower concern level than doctors and nurses thought patients would have. There were 2 exceptions where the reverse was true, and actually doctors and nurses underestimated the concern. And that had to do with the 3-hour observation period required after olanzapine palmitoate long-acting injectable because of the potential for the post-injection somnolence, sedation, coma syndrome should all of the medication after laceration of a blood vessel enter the system at once. This is a mechanical problem and not an allergic reaction, and only can occur with olanzapine long-acting injectable. Interestingly, the lowest level of concern was seen in patients who actually had experienced long-acting injectable treatment, having concern levels generally at 10% or lower. What are the potential reasons against and for LAIs? Looking at patients, they could actually say, oh, I might have more appointments, but often it is actually less appointments necessary because injection intervals are now not only 2 weekly and monthly, they can even be 6 weekly, bi-monthly, or even 3 monthly. The perceived stigma has to do with the fact that in the past, long-acting injectables were given mostly to the non-compliant, very sick patients, and receiving this medication was more of a punitive aspect. Nowadays, we realize that giving long-acting injectables earlier can be helpful for the illness trajectory, and therefore that negative image of LAIs should definitely change. The conversion from oral to LAI treatment can be complex, but there are clear guidances, and in clinical care, this is not really a problem. The fear of pain is a definite potential reason, but fear of something is generally higher than the actual reality. When looking at pain ratings, we've seen that with the second generation long-acting injectables, there is significantly less pain because they are water-based than with the older first generation antipsychotics given as long-acting injectable depots because they're oil-based. Moreover, in a meta-analysis that we conducted, pain perception in people with schizophrenia was significantly lower than in the general population. Inflexible dosing and stopping is one concern. However, one would only use a long-acting injectable after one had enough oral treatment possibility to actually fine-tune and dose and see whether the patient responds to and tolerates the actual medication. Clinicians might have lack of experience, which hopefully will change with a broader use, but also many clinicians do not fully appreciate yet the possibilities that LAIs have across the illness course, because in previous guidelines, long-acting injectables were reserved for people who've had multiple relapses or are taking them or are asking for them. Nowadays, we want to do preventive, not reactive treatment, and that means preventing relapses that can alter the illness course by implementing long-acting injectables earlier, because they don't only constitute a treatment tool, they're also an informational tool that everybody realizes when in fact the patient might become non-adherent. Cost and insurance coverage can be an issue, but as mentioned before, the actual cost of relapses, hospitalization, and more outpatient visits when patients worsen is higher than the additional cost of medication compared to oral medications. And also the indirect cost of not being productive and being on insurance-related money for not being at work is an additional cost. What are the advantages of LAIs? Well, there's continuous antipsychotic coverage. The pharmacokinetic area under the curve is more efficient. One needs to give less medication, and there is less peak-trough variation, whereby the peak levels are more related to side effects. Because of more continuous treatment, there are lower relapse rates, less hospitalizations. Patients who have cognitive issues do not need to remember and can't forget. When there are caregivers involved, there's less conflict over suspected non-adherence or patients feeling infantilized by being checked on by their loved ones. There's more flexibility to travel, and in a meta-analysis, due to less peak levels, lower hyperprolactinemia has been seen. As mentioned before, for clinicians, the advantages also outweigh the disadvantages. Previously, a con argument has been that guidelines have reserved LAIs as third or fourth line treatment. However, these guidelines have been changed appropriately due to data that has emerged, showing that outcomes on long-acting injectables are superior to oral treatments, particularly in samples that are more real world, as I will show later. There have been some mixed outcomes of LAIs versus orals in randomized controlled trials. However, in these trials, patients on oral treatment were as compliant as patients on LAIs because it's a selected patient population that participates in blinded randomized studies. Many of the younger psychiatrists might not have had enough training and experience with LAIs, but this has also been changing recently. Switching and time investment has been a counter-argument, but again, the front investment of explaining LAIs to patients and families saves a lot of time later down the road when patients are more stable. The dosing and stopping, as also seen for the patients, can be countered by finding the right dose during the oral titration in the beginning. Obviously, it's much easier to have long-acting injectable clinics so that the clinician doesn't have to give these injections. Not all services have that available. The benefits of LAIs need to be appreciated more. And then also, sometimes clinicians feel that they're taking autonomy of the patient away, that they might insert the doubt of adherence and that the alliance might be weakened. As a matter of fact, when a patient is more stable, we are giving them the autonomy back. And when we phrase it that non-adherence is a human condition and not necessarily only part of the specific patient, and that we don't doubt them, but that it's hard to maintain medication taking as prescribed, we don't insert doubt into our relationship, but rather can signal care. The lack of conviction and enthusiasm hopefully can be changed by looking at the real-world data as well as randomized trial. The pro arguments are similar to the ones for patients: assured medication delivery. You don't have to guess whether or not the patient is taking the medication, whether they're breaking through ongoing treatment, and you need to change the dose or the medication or add something, or whether it is behavioral because patients don't take the medication as prescribed. There's a common clinical overestimation of adherence in our own patients, and that is countered by giving an LAI because you know patients are taking the medication. You're uncovering covert non-adherence, directly signaling non-adherence, and there's less peak to trough blood variation. There's greater patient autonomy through better illness control, and therefore more flexibility and better adherence and alliance. As mentioned before, in randomized trials, we were unable to show advantages of the LAI versus oral treatment, but that had to do with the fact that basically there was no difference in adherence levels. Patients had illness insight, wanted to be studied, and also knew that their adherence was checked. Going away from randomized trials to so-called mirror image studies, where a change in treatment is looked at, comparing the time before the change of the treatment and afterwards in the same patient, i.e. doing what we do in clinical care, where we don't compare two different patients, but rather the status within the same patient before and after an action. In that type of meta-analysis of mirror image studies involving 6,000 patients, we were able to show that there was a significant advantage in the post-switch period after the long-acting injectable had been implemented. Not only was the hospitalization rate decreased by 57% for the first hospitalization and by 2/3 for multiple hospitalizations, actually 23 of the 25 studies individually without meta-analytic pooling showed the same result, that the LAI time that the patient had significantly better outcome than the oral treatment phase in the same patient. Why is that? Looking at an insurance claim database study where nobody had to give informed consent or knew that the data were being looked at later, actually those patients who were switched to a long-acting injectable formulation 12 months before that had only to 40% to 40% of the time the oral medication in hand, let alone what they swallowed. So there couldn't be a good outcome because 60% of the time there was no medication that the patient had collected from the pharmacy. When the same patients with that ambivalence over their illness or medication taking were switched to a long-acting injectable, that adherence level almost doubled to close to 70%. Finally, in a third meta-analysis of over 90,000 patients, we looked at cohort studies where patients are treated based on clinicians' and patients' choice, and found again, even though patients on the long-acting injectables were sicker, that the outcome was significantly better on the long-acting injectable, reducing hospitalizations significantly. How do we communicate long-acting treatment options to patients? We can only succeed when we really believe in the advantages and also communicate them. In a study where doctors were audio taped while conversing with the patients, their own patients, about LAI treatment, it was observed by linguistic processing that these physicians talked about benefits of the injectable medication only 9% of the communication time. 91% of the time was spent on neutral information or negative information. How do we expect patients and families to accept to something that we promote so little? Fair would be at least 50-50. During this conversation, still a third of the patients said that they might try and consider an LAI. When a day or two later, a doctor came to explain the LAIs again, who was more convinced and trained in the communication, actually 96% of patients said that they would potentially try it. This doesn't mean that they actually took the medication. So in a large cluster randomized trial in the United States, the Prelapse study, we randomized 19 sites to delivering either to first episode patients or early phase patients in the first 5 years of illness, usual care with the aim to go to long-acting injectables as the name of the game, or we randomized them 20 sites to just receive usual care. We trained the staff members for 2 days, giving them information, but also doing role play. What happened in the 19 sites where patients had been randomized to being offered an LAI by trained team members, not just physicians, we trained everyone, caseworkers, social workers, psychologists, nurses, doctors. Out of the patients eligible, 14.4% said they didn't want to talk to us anymore because we would offer them a long-acting injectable. So we didn't have time to spend more time with them to actually explain the treatment. Out of those patients who agreed to be followed, 91% of patients got at least one injection over a 3-month warm-up and engagement period at these outpatient sites. 91%. If you subtract 14%, basically 3 out of 4 first episode and early phase patients at least tried out and could potentially benefit from long-acting injectable treatment, showing that with adequate treatment and adequate explanation and training of staff members, there is a possibility that patients and families try out a long-acting injectable option.
Let's summarize with our SMART goals: specific, measurable, attainable, relevant, and timely. That is what we hope that you will take from this discussion to apply to your practice. We hope that you will be able to identify barriers to implementing long-acting injectables, or LAIs, and develop strategies to overcome them, and implement the use of LAIs early to quickly stabilize patients with acute schizophrenia and optimize recovery and long-term maintenance. Thank you for joining us today for episode 1 of our 3-part CMO Cast series. To review additional episodes on differentiating the mechanisms of action of current and emerging therapies, as well as recent clinical data on the safety and efficacy of current and emerging therapies for schizophrenia, please visit www.cmeoutfitters.com.